Advanced prenatal testing is going to cover some of the procedures that you could do in a pregnancy, but are often not done. The risk of most of these, except for one, is going to be fetal loss because you introduce a needle where it shouldn't be. We're going to talk about each of these procedures in relation to the procedure itself, when it can be used, that is, at what gestational age, what is the benefit or the goal of doing that procedure, the risk to fetal loss, and generally when we say risk in pregnancy we mean fetal death, and then any extra information you need to know that's interesting or that could come up on the test regarding that procedure. The first one is going to be the ultrasound, and the ultrasound is extremely safe. The risk to fetal loss is nothing, which makes it the go-to test in obstetrics. Most training centers now require their residents to be able to ultrasound a fetus. But technically, the ultrasound is an advanced procedure because it doesn't involve screening labs or history and physical. It can be used at any gestational age, and when you use it, it's going to determine what you're going for, what the goal is. In the first trimester, the ultrasound is used to determine an intrauterine pregnancy, determine gestational age, and assess for multiple gestations. In the third trimester, you're going to use the ultrasound to assess for fetal well-being in the biophysical profile, for example, and to confirm lie or orientation. You can also use the ultrasound to determine if there's oligo or polyhydramnios, which is generally going to be used somewhere intermittently between there. The thing you need to know is how to do the ultrasound, and in your rotations as a clerk, you may not have the opportunity to become a master at it. If you go into obstetrics, you're going to learn how to use the ultrasound quite well. The thing that comes up on the wards and the boards is how sure are you of the gestational age using the ultrasound? It happens to correlate which trimester you use it in with how sure you are. That is, in the first trimester, you're reasonably sure of the gestational age plus minus 1 week. First trimester, 1 week. In the second trimester, the ultrasound is reasonably going to tell you the gestational age plus minus 2 weeks. Second trimester, 2 weeks. And there, in the third trimester, the gestational age will be estimated within a margin of error of plus minus 3 weeks. Third trimester, 3 weeks. The idea is, if mom comes in late and hasn't had any prenatal care, you can't use the ultrasound to determine how old baby is. If mom comes in early on and you're confirming an intrauterine pregnancy, you can be reasonably reassured how old the fetus is. Ultrasound, go-to test. Remember the trimester to variation on gestational age correlation. Using the ultrasound in a different way is not routine, but just as safe. That is the transcranial Doppler, done after 20 weeks in the setting of fetal anemia. This is the alloimmunization we have a lesson on later on in the obstetrics course. If you have the right setting, mom is antigen negative but antibody positive, baby is antigen positive, and you have the right type and insufficient titers, and you're worried about mom's immune system attacking baby's blood, then what you need to do is assess for fetal anemia with a transcranial Doppler. Because it's an ultrasound, there's no risk. And what you do is you measure blood flow. It is assumed that if the blood flow is normal, then there isn't an increased cardiac output because the oxygen delivery is fine, which means baby's hemoglobin is fine. If there's an increased velocity, it means that baby's hemoglobin is low, so they're pushing blood through faster in order to accommodate. Therefore, what you're doing is actually screening out fetal anemia. This test is highly sensitive, such that if you have transcranial Dopplers in the normal range, you don't have to worry about fetal anemia anymore in that pregnancy. But transcranial Doppler does not provide a diagnosis. You have no idea what the hemoglobin is, and it provides no access. So if you need to treat baby, you won't be able to. We're going to come back to this at the end. We're doing this in increasing risk. The amniocentesis used to be the go-to test. And generally, it was used after 16 weeks, up to term. And you could use it for a couple of things. It's still used for genetic disorders, such as Down syndrome. You take a needle, you put it through mom's belly, into the amnion, draw off some fluid. In there are baby cells. So it allows you to confirm genetic disorders like Down syndrome. The risk of fetal loss is about 1 in 300. And if you're using it in the second trimester, it's only reliable after 15 weeks, and you're doing it for genetic screening. Because there are non-invasive procedures that can be used to screen for these diseases, check out the lesson on genetic disorders where we talk about the triple quad screen and cell-free DNA. Because we have those, the amniocentesis has fallen out of favor. There's a risk to fetal loss, and by the time you get the results, if you can only get the sample at 16 weeks, it's pushing 20 weeks, which comes up with an ethical issue and technically more challenging to terminate. We used to use the amniocentesis, and you may still see this, for fetal anemia, and we used to use it for lung maturity. In a premature infant, we asked, should we give corticosteroids? We do not use the Lilly-graph, and we do not use the lecithin to sphingomyelin ratio from the amniocentesis anymore. It used to be that we would try to use the Lilly-graph, but we don't use it anymore for fetal anemia, and we used to use it to determine the lecithin to sphingomyelin ratio for lung maturity, whether we give steroids. Now we have the transcranial Doppler and the pubs for fetal anemia, and we have just to give steroids if it's going to help. And if it's a premature infant, chances are you're going to give those steroids. And speaking of genetic testing, the chorionic villus sampling is far better than the amniocentesis. It can be used as early as 10 weeks for the same purpose. You're going to be screening and testing for genetic disorders like Downs. You're going to get direct access to baby genetic material so you'll actually be able to see the karyotyping and actually run the genes. The fetal loss here is a little bit higher, and it's a little bit higher because you're accessing baby at a more sensitive region earlier in the pregnancy. And because it can be done so early identification allows for early termination. In high-risk pregnancies, where mom may know that she has a high risk of having these genetic disorders, she may want to take the risk early on in order to terminate and try again. And lastly, we're going to talk about pubs. That is percutaneous umbilical blood sampling, where you actually stick a needle into the umbilical cord and you sample baby's blood. This is only going to be done in a period of viability greater than 20 weeks, but less than 34. That is not close enough to be delivered. That is, in the setting of fetal anemia, they screened positive for the transcranial Doppler. Now you use the pubs to both confirm the diagnosis and fix it. It does allow for access, so you can transfuse through a pubs. And it allows you confirmation by giving you an actual hemoglobin, and you know exactly what baby's hemoglobin is. The thing is that if the transcranial Doppler is negative, you never get to this step. And if the transcranial Doppler is positive, most of the time you are just going to deliver. That is, near-term babies get delivered. But if they're in that window of just after viability and not quite at term yet, then you may end up transfusing baby. We talked about 5 different procedures: the ultrasound, the transcranial Doppler, amniocentesis, chorionic villus sampling, and PUBs. Ultrasound, always safe, probably the right answer. Transcranial Doppler, screen out fetal anemia in the right setting of albuminization. Amniocentesis is almost always going to be the wrong answer. Chorionic villus sampling allows early detection and therefore early termination in the first trimester and gives you a definitive diagnosis of genetic material. PUBs is used in that window of greater than viability but not quite at term in order to confirm fetal anemia and transfuse. That is advanced prenatal testing.